Yeah, I think so. Yeah, I just got to go. So welcome, good morning and good evening, everybody. So my name is Rainer Empele. I'm the Director of Marketing here in the United States for Aesculap Neurosurgery, and it's my pleasure to welcome you here to our fourth Aesculap Aneurysm Expert Talk webinar of the series, Clippology with the Masters. We have close to 600 signups, which is an amazing indicator that we have an amazing faculty today, again with Dr. Lawton and Dr. Tanikawa from Japan. Please consider that this event will be recorded, and right after the event we will share the recording link to all of you so you can share it with your peers and friends and promote this webinar series even more. Because we have a lot of participants signing up right now, if you have trouble to sign up or technical challenges with Zoom, please text to the number 484-294-0255. Of course, if you text from international, please add +1 as the country code of the US to that number. A very short message from our legal team. So when you're using the products that will be presented and shown in this webinar series, please refer to the instructions for use for indications, contraindications, and for other product-related information to make sure you're safely using the products that are mentioned in this series. The Clippology with the Masters is case presentations and techniques. For the most part, it's very complex and difficult cases. I'm excited to see the cases that Dr. Lawton and Dr. Tanikawa are presenting. But most importantly, this session today is supposed to be a dialogue. So please make use of the expertise of our host, Dr. Lawton and Dr. Tanikawa as our special guest, and type in your questions, your comments in the chat within Zoom, and our speakers are happy to answer them, and we have enough time to address your questions so that it's a real good discussion and a dialogue that we have in this webinar. Before Dr. Lawton will introduce our special guest, Dr. Tanikawa, let me say a few words about our host. Dr. Lawton just completed and finished his aneurysm case number 5,000 that he posted on LinkedIn, which is an amazing number, outstanding. So congratulations to you and your team at BNI, Dr. Lawton, for achieving that milestone. And very close, I guess you're getting towards the 1,000 AVMs as of today. Dr. Lawton is holding both a degree in biomedical engineering from the Brown University and also a medical degree from Johns Hopkins in Baltimore. Dr. Lawton actually started his residency at BNI in Phoenix and completed there also a fellowship. And then after a couple of years of course, education and expertise, he returned a few years to BNI, where he is today the president and CNO and professor and chair of neurosurgery. Dr. Lawton, it's my pleasure to have you as the host for our fourth webinar with the record-breaking participation already today. The stage is yours, and thanks for hosting that webinar.
Thank you, Reinhard. Let me do my screen share here.
Done.
Okay, well, it's a great privilege for Aesculap, for you all hosting this Clippology session, and we're excited to launch what really amounts to season 2 for Clippology. We had a great response in season 1, and we're excited to continue this. I don't want to spend a whole lot of time with introductions. I just want to say a few words about Rokuya. He's a dear friend of mine. This is a picture from when he was here in what was one of the very last meetings before the pandemic hit us. we did a course which we called the Last Samurai course, or an East meets West aneurysm anatomy and cadaveric dissection course. And you can see that with the samurai sword, we both feel like this is a vanishing art that we have spent our lifetimes committing ourselves to, and we feel strongly about trying to preserve it, and that's what that course was all about. I happen to feel that Rokuya is one of the finest technical neurosurgeons in the world. He's one of the finest I've ever seen operate, and so it's a real honor for me to invite him to be the lead guest for season 2. So with that, Rokuya, welcome. I'm going to exit my screen share here, and I'm going to turn the stage over to you because you told me you've got some great cases, and I always love and marvel at your work. So I'm going to just let you launch in.
Thank you, Michael. Can you hear me?
Yes.
Okay. Yeah. Again, thank you very much for your see you through the Zoom, and but as I told you, looks good. Everybody looks good, even in this difficult pandemic situation. Anyway, it's a great honor for me to present my experience about the exact clipping as a clippology. I can show you my several cases. Can I start?
Yeah, we can see.
Okay. Okay. Clippology for appropriate treatment of cerebral aneurysm. Before about the talking, I have to show you, explain you the principle of the surgery, especially preparation. Everybody knows that the patient positioning and monitoring during surgery in aneurysm surgery is very important. The patient head and neck should be slightly extended, and this means that we need to be careful not to compress the internal jugular like this. If the too much flexion of the patient head, we may compress the internal jugular at the neck, and it may cause the elevation of a venous pressure, and it happens too much bleeding during surgery. To avoid such a complication, we need to reduce the venous pressure by taking the patient position appropriate. And the patient head should be rotated to the other side if we operate through the internal approach. I usually use a head rotation 30 degree in a internal approach in all cases for middle cerebral, carotid, ACOM. And if necessary, we can rotate the patient bed during surgery to an appropriate degree. And if the patient have the strong atherosclerotic change of internal carotid system, I usually open the neck before the craniotomy. And the monitoring, I use the transcranial MEP and ultrasonic Doppler probe and IC green angiography. This is the brief explanation about the positioning and the monitoring. And I always emphasize that bloodless operative field is very important. And of course, wide separation of a Sylvian fissure, wide splitting of an interhemisphere fissure to get the wide intraoperative field to manipulate aneurysm to apply the clip. The applying clip, you know, the applying clip angle has a variation from the base side, from the vertex side, or very right side, left side. So that we need the wide opening, and gradually the target field is getting closer. So we need a wide opening, and preserve all veins. This is very important to avoid the post-operative any complications like a brain edema, the venous infarction, whatever. When we try to avoid such a post-operative complications, the preservation of veins is very important. And when we manipulate the aneurysm during approach, the highest magnification is very important to confirm the tiny structures, including small veins. And when we detach the important vessels, perforators on the dome and the parent arteries, we need the highest magnification to detect the exact and the appropriate dissecting plane. So using a microscope, this is the big advantage that we can use the highest high magnification. I usually perform the closure line clipping. The closure line clipping is defined by Professor Ishikawa almost 20 years ago. This is a publication in 2009 in Japanese neurosurgery journal, Neurological Medical Chirurgical. In this article, he described that aneurysm formation before the normal bifurcation make the aneurysm like this. And if the aneurysm is one side, the branch of parent artery, the neck is getting wider to this side, this parent artery, and much more, the aneurysm almost riding on the one small branch. Anyway, these are the variation, but basically the principle of the aneurysm formation at the arterial bifurcation like this. In this case, the closure line clipping means that the clip blade should be placed here and here. Then you can close here, not parallelly, the perpendicularly. Then we can close all the neck in a three-dimensional way. This is a sample drawing by my colleague Cosmo Noda. We usually perform the multiple neck clipping like this to close the whole whole neck. And the wide operative field is necessary in a Sylvian fissure. Usually, even the MCA aneurysm, we open the fissure like this, expose the M2-3 segment, and expose the MCA bifurcation in the bottom of the Sylvian fissure like this. Not only horizontally, but also longitudinally, we need a wide operative field. Then we can try to do a several angle clip applying with a clip forceps. This is a 47-year-old female anterior corridor aneurysm, ruptured, the Hunt and Cosney grade 3, double Hess grade 4. I operated this patient this week. 2 days ago. 2 days ago, the day before yesterday, I operated this patient. So you can see the widely cerebral fissure is separated and exposed aneurysm. You can see the rupture point right there. And this is a duplicated MCA. Duplicated MCA and distal ICA is clipped. The neck is controlled in a common carotid, proximal control. And this is a small branch coming to a temporal lobe. And in the proximal neck, you can see this is the trunk of anterior carotid artery. And carefully you observe, you can see here, the very small branch is adherent on the proximal neck of aneurysm. I'm trying to detach this small branch because in my experience, the most proximal branch like this is always feeding internal capsule. So this is a very important branch to preserve. Anyway, the appropriate neck closure is necessary with preserving any branches from anterior carotid artery. The IC green shows looks good. The important branch I dissected was preserved, and the remaining part of the aneurysm is occluded by so-called tandem clipping. I used the 720 and 692. And now I'm detaching the rupture point. It is adherent to the uncus, and it is sharply detached from the uncus. And the purpose of this manipulation is to confirm, to expose all the carotid artery branch and confirm all the branches preserved or not. Now you can see, look, the branch I detached from the proximal neck was bite. It is bite, so I tried to replace the clip. But even under the proximal control, the bleeding comes so much because the picum is still open. So I put the second clip not to have a bleeding like this. Then you can remove the first clip. I'm carefully removing the first clip, replacing first clip. And once I removed first clip and carefully replace the first clip, not to occlude the important branch by tip of clip. Here, the tip of clip is placed almost good position. By removing the second clip, the bleeding comes. So I put the second clip again, and I'm trying to remove the first clip. And this is a coagulation of the injured part of the dome, and I'm taking out the shoot aneurysm part. And this is a final appropriate placing of a clip, not to remain the very medial part of the aneurysm dome, aneurysm neck. Now, again, IC green shows all the branches. This branch was a very important branch in this case. And again, the remaining part is closed with a second clip as a tandem clipping. And then you can finish the surgery like this. The patient recovered well. Immediately patient waked up. And patient now, the consciousness a lot. The before surgery patient had aphasia and a slight hemiparesis, but all the neurological finding recovered. That was good. And this is I can
stop there for a
this.
sec and just talk a little bit about your case.
Okay. Step by step. Okay.
Yeah, I think it's a great demonstration of how you have to handle the anterior carotid artery aneurysm. I think it's very easy to see or look for just one main trunk, and oftentimes there are these other accessory or minor trunks, and your case very nicely shows that there were many. I counted maybe 2 or 3 accessory branches off choroidal, and you never know which one of those is actually your key artery going to the internal capsule or to the optic radiations. And so I think that case is a really nice demonstration of how you have to really meticulously check each one of them and make sure that they're preserved. I think that was a nice part of your case. The one question I have for you is your use of temporary clips and your trapping of that segment, the communicating segment of the carotid. It's always a little bit nerve-wracking for the choroidal, in my mind, to isolate or cross-clamp that segment, because I think it's like any perforator. Sometimes the ischemic tolerance is lower than you expect. It's more like a lenticulostriate artery sometimes than like a PCOM or another major branch. And I wonder what your thoughts are on like what pressure you put on yourself to hustle through that, or what time limits you use in your mind as you go about that.
Yeah, I think in any case to do a temporary clip on your carotid system, the 5 minutes is a best shortest time to do, but depends on the case. Actually, in this case, I spent 10 minutes in a first temporary clip, and during a temporary clipping, in this case, we could perform the MEP monitoring, and after beginning of a temporary clip at the carotid and cervical carotid and intracranial carotid, I asked the technician to do a MEP monitor every 1 minute. Then in this case, nothing happened even after 10 minutes. But depends on the patient. If the collateral and anterior carotid artery territory, perforating artery territory, the collateral pathway was not good enough, the immediately 1 minute 30 seconds patient MEP disappeared. In such case, we have to shorten the temporary clip as much as possible. But depends on the case, difficulty of the case. This case was relatively good.
What did you feel like the exposure in the neck was necessary? It seems like you could have had a clip on the supraclinoid carotid intracranially and achieved the same trapping.
Yeah, I have an experience of crinoidectomy to secure the C3 segment intracranially, but recently I did not do it because one reason is to expose the C3 segment after the crinoidectomy. This means that the carotid oculomotor membrane should be open, and you need to expose the carotid wall at the C3 segment. And the opening of a carotid oculomotor membrane might be causes something venous hypertension of the orbit, and it may cause the visual disturbance. So the recent 5 years, I avoid to perform the anticrinoidectomy in order to secure the C3 carotid. This is the first reason. And the second reason is, as I mentioned in the first explanation in the beginning of my presentation, this kind of patient patient relatively have the severe atherosclerotic change, the arterial plaque on the, even in a C3 or a supracrinoid carotid segment. In such case, to put the temporal clipping on the hard atherosclerotic part, I have a bad experience of arterial dissection and occluded carotid after the temporal clipping removal. So to avoid such a complication, I open to secure the common carotid and external carotid.
Okay, good. You
Yeah.
want to go on to your next case?
Okay. Just a moment. Okay, I'll show you ACOM aneurysm, unruptured ACOM aneurysm, interhemiscleral approach. This is a bifrontal craniotomy. And after the anterior interhemiscleral approach, I am going to explore the aneurysm. You can see the aneurysm dome is so strong adherent between the aneurysm dome and the right A2. And here is the right A1, tiny right A1. Bilateral A1 is occluded. And I am trying to detach the aneurysm dome from right A2. Successfully, the aneurysm dome could be detached, but you can see it's dangerous. The advantage of the aneurysm is removed out. But fortunately, nothing happened. And I put the two clips, and the final clip is a fenestrated mini clip. And this aneurysm has a relatively wide neck. I occluded the relatively wide neck with the 3 clips. And you can see the hypothalamic branch, all the tiny branches preserved. And the post-operative CT angio shows a complete neck clipping, and illustration before and after. It is drawn by my colleague, Dr. Suzuki. He's a still resident, 5-year resident. He drawn very well what we did. This is one of technique of multiple neck clipping using a fenestrated clip as a interlocking neck clipping. I often use this technique for occluding the wide neck, like almost more than 180-degree the neck orifice. This is the second case.
Yeah, you know, it's interesting. We were talking about your affinity, your fondness for the interhemispheric approach for your ACOMs. And I think it's a much harder fissure and a much more unpredictable fissure to open. Like here, obviously, your separation of the frontal lobes was perfect. There wasn't any bruising or subpeel problems. But in many of these cases, particularly when you're going so anterior, you've got PIA opposed to PIA, and things are very stuck, and it's hard to get that nice separation. And so by the time you get down to the ACOM, it's not always as clean as you want it to be. And I just wonder, you know, can you give us a sense of how many of your ACOMs you go through the bifrontal interhemispheric route, and how many you go through the subfrontal terional route?
Yeah, it's a good question. Yeah, you know, I prefer interhemispheric approach for ACOM aneurysm, and yeah, I do a terminal approach as well, but the ratio between ACOM and the terminal approach is 9-1. 10% of terminal approach. So In the case if the patient have the ACOM aneurysm and simultaneously carotid, MCA, and distal basilar aneurysm, I do a terminal approach as a distal transscleral and anterotemporal approach and approach to ACOM simultaneously. And in such case, the deeper aneurysm is clipped first. So the distal basilar clipped first, second carotid first, and the next ACOM. And finally, I do the middle cerebral.
This case is a nice example of how your approach actually helped. If we had done this terionally and we had to dissect the dome off of the inside edge of that A2, it's a much harder dissection maneuver when you're going subfrontally than it is when you're coming from the top. So I think that's a nice demonstration of how yours has advantages. But sometimes you can't predict that. You don't know going in that you actually are going to need that vantage point or that you're going to have that adherence to deal with.
Yeah. So the advantage of interhemispheric approach is to expose the ACOM complex, and you can confirm all the complex ACOM anatomy, especially as I showed you in this case. You can see here if the aneurysm is projecting superiorly like this, aneurysm is projecting superiorly like this in between the bilateral A2 like this. The ACOM, the aneurysm dome was attaching like this to the right A2. Then it is very, very hard to see through the inferior side through the terminal approach. So to diagnose the anatomical structure, adhesion of the parent artery to the dome and neck on the preoperative CT angio 3-dimensionally, we can rotate it, confirm all the directions and all the structures. This is very important. So this is the biggest reason why the dissection detaching the parent artery from the aneurysm dome looks difficult in a preoperative discussion. So this is the reason why I decided to use the anterior interhemispheric approach in this case.
Yeah, and let me ask you this: if in that dissection along the dome and the parent artery, you were to get into the dome and have an intraoperative rupture, what are your maneuvers in that setting? Like what were you thinking in this case? If you had gotten into the dome, what were you thinking?
Always I have to occlude the before touching the aneurysm, you have to secure the bilateral A1. In majority of cases, the one side A1 is dominant, the other side is left side. Anyway, both A1 should be secured before touching aneurysm. And if it looks safe to detach the aneurysm from the surrounding structure, you do not need to put the temporary clip beforehand. But if the aneurysm dome was very fragile and it looks dangerous, I always put the temporary clip on both sides, then start the dissection of the aneurysm dome. But very rarely you have the accidental premature rupture during just a gentle touching, even gentle touching, the accidental premature rupture happen. In such case, we need to put the temporary clip immediately, of course. But anyway, in any situation, when we expose the aneurysm in operative field, we have to at least confirm the position of the proximal parent artery, both bilateral A1 and A2. And if something happened, immediately you have to put the temporal grip on the proximal parent artery.
Yeah,
I
think it's a very challenging maneuver, but it's so important because once you break through that cleavage plane and you see that other side of the neck, the clipping becomes very easy. In my mind, what I always try and think of is, I want to really protect the parent artery. I can afford to get into the aneurysm, but I can't afford to get into the parent artery when I'm going down that adherence plane. And so I always try and err on the side of the dome rather than the parent artery, because that's basically going to be shut down anyways with your clipping. So if you do have an accident, you want to make sure it's on the aneurysm side and not the parent artery side. The other thing is it's often hard to reestablish that plane once you've gotten into the aneurysm. If you have that accidental rupture and then you haven't gotten all the way down to the neck, it's sometimes very difficult then to bring that neck together below your rupture site. And I think that's where the real danger of this maneuver is you then have a hard time, even with temporary clipping or temporary trapping, getting those tissue planes reestablished in your clip in the right spot.
So I'm not sure whether this is a exact answer for you. I think when fully expose the aneurysm neck and detaching the aneurysm dome and the neck from the parent artery, sometimes the true neck has a very fragile wall, and just touching the neck and the parent artery, the junction is injured and the bleeding come out at the neck. So in such situation, I put the temporal clip in both proximal A1, both distal A2, and the four direction occlusion. Then I try to stitch the injured point directly and to make the injured part stronger. And then I try to put the clip to do a complete closure line clipping. In such situation, parallel clipping is another solution to get the complete neck clipping.
Okay, let's do one more case. Pick your favorite last case from your collection there, and we'll do that one next.
Okay. Okay, I'll show you distal basilar SCA aneurysm. This is a very elderly patient, but patient strongly hope to undergo surgery. The basilar, relatively large basilar aneurysm. This is the right side front temporal craniotomy. In this case, we are planning to do a anterior temporal approach subdurally and epidurally. This is a preparation for epidural anterior temporal approach. But before epidural approach, we try to separate the distal cerebral fissure. Then almost cerebral fissure is open. Because of a venous structure, the dura propria should be peeled out from the cavernous lateral wall. Now the lateral cavernous wall is exposed, and I am opening the oculomotor foramen and trochlear foramen, and I am freeing the. Now it's a first nerve. The space, first nerve and the fifth nerve V1, The oculomotor foramen is already open, and I am opening the space in between the first nerve and the V1. You can see here, this is the first nerve, pons trochlearis is almost open. And the first nerve is mobilized medially. And additionally, the dura propria elevated posteriorly, and I am confirming the C4 carotid. And this is a oculomotor foramen, and this is a manipulation of a cavernous segment oculomotor dissection in order to mobilize the oculomotor nerve, because the aneurysm and the basilar trunk has a very tortuous atherosclerotic change. That this even carotid has a very strong atherosclerotic change, and this is a mobilization of a first nerve, and by this manipulation, the roof of a cavernous sinus is open. The fibrin-soaked gel form is packed to stop the bleeding. This is an extension of the Parkinson's triangle in between the first nerve and the fifth nerve. And by incising the roof of a cavernous sinus, you can see in the depth that is a Greuer's ligament. That this means that the inferior petrosal sinus outlet is opened at the posterior cavernous. And this is the incision vertically toward the base side along the clivus, the partially opened the posterior cavernous sinus. And this is the incision of arachnoid membrane along the basilar trunk. You can see the basilar trunk, that we can get the space to put the temporal clip to a basilar trunk just lateral to a fourth nerve and the third nerve. And then you can confirm the aneurysm and the neck, that this is the aneurysm dome is strongly adherent to oculomotor nerve medial side. And here, the adhesion of aneurysm to a brainstem, the superior cerebellar and P1 is confirmed, and trying to put the complete neck clipping, not to clip the small perforator posterior to the aneurysm. With the highest magnification, that you can see any structures, all the structures. In this case, the clip manipulation should be medially to an oculomotor nerve, and proximal control should be laterally to an oculomotor and the first nerve. In this case, before surgery, because of a very tortuous atherosclerotic change of basilar artery, I expected to perform the transcavernous approach in order to secure the basilar trunk. This is the reason why I combined the intradural transcerebral anterotemporal approach and the epidural transcavernous anterotemporal approach. Then the dural closure is performed. The temporal side is fixed with the duragen and the fibrin groove. And this is the final view. And you can see the complete neck clipping is performed, and the diffusion image shows a no high signal. And this is a drawing by my illustrator. What we did, not only the opening oculomotor foramen, but also fourth nerve dissection between to extend the Parkinson triangle, and by opening Parkinson triangle partially, that we could confirm the Groover's ligament and the opening of inferior petrosal sinus. And in the video, it was difficult to see to confirm the sixth nerve, but just beside the inferior petrosal sinus in the right side drawing, you can see the always sixth nerve is coming up, straight up toward the C4, C5 junction, and it is coming out to a C5, C4 lateral surface just medial to a V1. This is a very important anatomy, and sometimes if you open here and inside the inner petrosal, very anterior inner petrosal dura vertically, we can get a lower space to secure the basilar trunk in a lower position. This is a interesting anatomy to do a clipping of distal basilar aneurysm. Thank you.
Beautiful case. It's an anatomic tour de force. But I guess the question in my mind is, you do the fourth nerve and third nerve mobilization to really essentially open your root for the temporary clip, which of course can really turn the tide in a case like this and make the aneurysm soft and help your dissection. But is it really necessary? Like, do you think that if you had just done a clinoidectomy, released the third nerve, mobilized it a few millimeters, 4 to 5 millimeters laterally, without dissection of the fourth nerve, without entrance into Parkinson's triangle, that you could have achieved the same result? Because if you look at your clipping root, you're still within the carotid ocular motor triangle, which is up high. Your low exposure really just got you your proximal control.
Your main question is
Yeah, I'm wondering how essential do you think the transcavernous component of this operation really is, or do you think that do you think we should be doing this routinely for the basilar tips? Do you think it's that important, or was there something about this case?
No, not routinely. Very limited, depends on the case. I do not routinely perform the transcavernous approach. If the carotid oculomotor triangle was wide enough to put the temporal clip and to manipulate the aneurysm, not necessary. Absolutely never necessary. But a very limited case like this, the carotid oculomotor triangle was very narrow, and that space was very very dangerous when we put the temporal clip into a proximal basilar trunk to the aneurysm. The clip applier may push the third nerve too much. And you may have the experience like that, the oculomotor nerve palsy after surgery because of manipulation, especially touching the clip applier touching to oculomotor nerve. To avoid this, I sometimes, occasionally, I use this approach. But this is a very complex and dangerous. You need to open the cavernous sinus. And so it's not always recommended. The indication should be limited, of course. And additionally, in this case, as you saw, the anticlinoidectomy is not necessary. Anticlinoidectomy is not necessary. Without anticlinoidectomy, you can see all the third nerve, fourth nerve, V1, like this.
Okay, well, I'd like to show you a case and show you what we did, and you can ask me questions.
Okay.
Can you unshare your screen, Rokuya?
Oh, sorry.
Okay. Right, I'm going to skip this one, and I'm going to show you this one. Can you see the this giant ACOM? So here it is. You can see that it's greater than 2.5 centimeters in diameter. It has a lot of thrombus internally. When you look at other MR sequences, you can see some of that concentric layering of thrombus. And down at the very bottom here, you can see just a little small luminal component there at the base. So it almost looked like your ACOM aneurysm, except that it's got all this other stuff layered on top of it. This is the rotational angiogram, and this just confirms the fact that it is largely thrombus filled. You wouldn't think much of it if you just looked at that rotational angiogram. But for this one, I felt like we weren't going to be able to clip this. There was just too much interluminal clot and a lot of atherosclerotic tissue and high probability of occluding some branch vessels if we primarily clipped it. And I would also point out to you that this is a dominant right A1. The right A1 is the only artery that fills the distal anterocerebral circulation. There is no A1 on this left side. So we opted for a bypass strategy and broke it down into inflow, communication, and outflow, and basically had to rebuild each of these different components. The A1 inflow to the circulation, we built that out with an M2-A2 bypass. To communicate one side to the other, we did an A3-A3 bypass distal to the aneurysm. And then for the outflow, we just let the natural flow of these of the circuit take care of business. So this is just what we did. The pink is our radial artery graft here, and you can see it's from M2 to A2. We did a side-to-side bypass here in the interhemispheric fissure to relocate the ACOM. And so, you can see that if you were just to occlude the A1 to close the inflow, you'd have nothing. So you really do need this injection of flow and also this communication across. And then these are our trapping clips. We did purposefully did not trap the outflow artery on the A2 because we needed this flow to come across and down and supply not only these proximal A2 branches, but also ACOM perforators, recurrent artery of Huebner on both sides. And so we're using a little bit of the aneurysm to complete that. So this is the view. Surgery, the frontal lobe is to your left, the temporal lobe to the right. And this is what we call a squeeze play, meaning we have both a bifrontal exposure and a pterional exposure. This is the bifrontal interhemispheric exposure. And figured we'd get this done first. So this is the view down onto the corpus callosum. These are the A3s heading back. And our first step is just this in situ bypass. And this is the interluminal suture line. And this, again, is just really, you can think about it as taking the ACOM, since you're going to be repurposing it. You're moving the ACOM distally in the ACA territory. So you've got to create a right-left communication, and this is the simplest way to do it. So that's done first, and that is going to take care of the distal flow. There's confirmation that we've got things working. And now this is the view subfrontally. So this is the A1 right here coming in. The A2 is coming out here. You can see some of the branches behind it and the rest of the aneurysm behind it. So we'll do the interpositional graft. This is the A2 recipient site, linear arteriotomy, radial artery that's been fish-mouthed. And this is our subfrontal anastomosis. So it's still possible to climb up the A2 and to get this in place. You can see the thickness of the tissues. I'm using a 9-0 monofilament nylon here. I'm running my suture. It's a nice way to do this. This is inspection of the inside suture line before we start sewing the other side. Here, just finishing that up. Now we've got the deep side of the bypass, and I like to do the deep suturing first because it makes it a little easier, and you want to take your advantages at the hardest end of the anastomosis. This now is in the Sylvian fissure, and we've got our M2 here. I'm going to sew this using what I would call a fourth generation technique, meaning I'm going to sew this first suture line interluminally. So you'll notice the needle is intraluminal on both sides, and the suture line is being sewed interluminally. What that allows me to do is to shorten this graft, keep it a little bit more streamlined, and once I've gotten that deep anastomosis, we can reverse our needle and oversew the other suture line in a more traditional extraluminal technique. So that now is the donor anastomosis. So the M2 is the donor, the A2 is the recipient. The circuit that we're creating is from M2 to A2, from A2 on the right side to A2 or to A3 on the left side through our A3 bypass. And now we've essentially recreated a flow circuit for the ACA territory. That gives us the freedom now to shut this aneurysm down. This is a clip on the A1. That takes the inflow. You'll notice the recurrent artery of Hübner that's right in between. And this is a flow on the distal side of the aneurysm, on the proximal A2. This is to keep flow from the bypass from getting into the aneurysm. So it's not a complete trapping, it's a partial trap. You can see that the recurrent artery is right there in between A1 and A2, and it's not been excluded, but that's by design. And when you look at this IC green, you see right here at my arrow, that's recurrent artery of Hübner flowing through, and the only way that that's filling is through the interposition graft, across the A3 bypass, down the other side, and through the aneurysm. The only way that that can get flow, and that confirms that the circuit that we've recreated has done its job. So here's our postoperative angiogram that just shows you that. The donor anastomosis is here. The recipient anastomosis is here on the A2. The aneurysm is between these two stumps here that just show up as a little flow void here. And our A3 bypass is up here at the blue arrow. And you can see the aneurysm is gone. It has thrombosed the rest of the way and taken care of itself. So that is my first case I wanted to show you, just to get your reaction.
Yeah. It's a extremely difficult case. But
this is the kind of case that you would have done in Helsinki routinely.
It's a hard work, very hard work, especially in Helsinki. It's too hard. Anyway, yeah, but this case is very difficult. Your decision of the procedure, surgical procedure, is very smart. Yeah, it's a very good way to improve the patient. The angiography, the aneurysm almost has gone, and all the important vessels is preserved. especially as you mentioned, the hypothalamic branch arising ACOM and bilateral Hoibner's arteries, though the very important vessel. With this procedure, the inflow ICIC bypass as a M2 radial artery A2 bypass works well, and distally to the bypass at the A3 side-to-side anastomosis, you made a new ACOM in the distal part of ACA. This is a very effective and useful procedure. I like it. You didn't touch the aneurysm itself, and not at all. It's a
Not at all.
very
I think you know, sometimes touching giant aneurysms is not a healthy practice, and sometimes I think if we're able to outsmart them and not touch them at all, then we win. That's kind of how I've come to look at these in many ways. And so I'm just curious, in your hands in Sapporo, how might you have done that?
Yeah, it's a hard to touch the aneurysm because like this case, the aneurysm is extending, invading a very important area of the deep brain. And if we try to remove the thrombus to touch the aneurysm and try to do a direct tripping, it's too invasive to the patient, and we may lose many neurological functions. So it's a good decision. And in Sapporo, I have several cases to perform the direct neck ripping, even such a huge thrombus aneurysm. But the aneurysm was located just in the frontal lobe. It's safe. I may have showed you the case maybe in EANS in Madrid during a luncheon seminar, something that you were there, and at that time, Jack Morcos as well. I showed you that case. That case was a
I
huge,
think I remember.
thrombus, and I did the A3 and the ACA bypass simultaneously. The procedure before attacking aneurysm is similar with you in this case, but in that case, I could remove all the thrombus inside, and finally I could make a neck ripping. But if the aneurysm was located just in a non-erocant area, it may be possible. But in this case, your procedure is the best.
Yeah, you know, the cases that you've shown me, I do remember them well. You've often resorted to the STA as your inflow construct. And I've always found that when I do my STA harvest, by the time I get up to the interhemispheric fissure and then down again, the vessel is so small that I lose confidence that it's enough. And I always find your harvest to be much more robust, and I still haven't been able to explain that, but I think that's the difference. You're somehow able to get a very distal, robust distal STA all the way down to the A3 or to the the closer marginal that gives you that confidence. Yeah,
because of the size of STA, the STA may not provide a sufficient blood flow to ACA territory. It's true. So depends on the size of ACA, and if the perfusion area is limited in the distal ACA territory, distally to a carotid marginal and the pericardial artery territory, the STA flow is good enough, even in a bilateral the interhemispheric branches. But as you mentioned, if we try to do the both ACA territory from proximal to distal part, the only a single STA is not sufficient. So in such case, we need something much more bigger graft, like you use radial or saphenous. Yeah, I agree.
I wanted to ask you one other question. You showed me a little trick in one of our recent meetings where when you do your A3 bypass, instead of the way I do it with a straight linear arteriotomy, you do a curve.
Yeah.
You do a curve because you think that it enlarges your anastomotic area. And
Yeah.
I've played around with that a little bit, and I still find it to be a lot harder to do. It kind of throws off my orthogonal way of sewing. And I just wonder, now that it's been a while since you showed me that, whether you're a believer that that curve makes a difference.
Yeah. Yeah, as you as you said, the making the curved incision and symmetrically like this, it's not easy at first. For me, it was difficult. I did this procedure at first time almost 30 years ago. At the time, I couldn't incise the vessel wall smoothly. That I made a zigzag arteriotomy. It looks bad, but by the several time experience, I could make the smooth curve. That we need the practice anyway. But you may realize that even just a straight incision, if as we discussed, if we make the sufficient length of the arteriotomy, it works well. We talked at least 3 times of length compared to diameter of the parent artery. At least 3 times longer. More than 3 times. Sometimes 4 times. Very long stitching.
All right. Well, I think I'll show you one last case because it sort of reflects your first case you showed us. So let me go back to my screen share. All right, so you can see the history here, progressive vision loss in the right eye, and this patient had this aneurysm. Not quite giant, but nearly so. You can see sort of that mushroom cap shape. Whenever I see that flat base of the aneurysm, I know it's going to be a little bit more challenging to reconstruct this. We approached this with a pretty standard pterional exposure, but like you in your case, you showed us, I got the neck out on this one because I intended to use the suction decompression technique. You can see now the carotid cistern, the aneurysm is buried underneath the optic nerve, and I like to do my clinoidectomies intradurally when they're that adherent to the aneurysm, just in case there's trouble. So this is my intradural clinoidectomy. It comes out very cleanly and gets me to the distal dural ring here. Very straightforward to circumdissect. And now we've got our proximal carotid exposed. We have a little retraction on the frontal lobe just to open this up a little bit more. Here's some more trimming of the dural ring. And I just, we can discuss this, but the suction decompressions I think you do using the STA. For this, I went into the common. I just find the common to be a little bit more workable and get a nice line of the needle or the catheter up the internal. So with that in place, we can go back and trap the aneurysm. That's a clip on the PCOM. This is a clip on the supraclinoid carotid. And now we can release the internal. Now the aneurysm is suction decompressed, and you'll see that the aneurysm is dramatically softer, but still, it's not like it just completely flattens. There's still flow from branches off of the carotid segment, but it's soft enough that we can get our first pilot clip on. That's a fenestrated clip, and it's important teaching point to make sure that you do a tandem clip for this. If you just use a single straight clip, it's often not enough closing force. So we have a fenestrated clip, a closing clip, and then some clips on the very near portion at the siphon as the carotid comes out there to tailor that fenestrated closure. So this is an interesting part of this case. When we do our IC green, we see that the stalk is back there, all the perforators in the back look fine, flow in the carotid is good, and we don't see any filling of the aneurysm. So on the surface of things, it looks like it's a job well done. And so here we're just finishing up, and these are replacing some of those contouring clips on that proximal neck. But you'll see here as I puncture the aneurysm, there's fairly brisk bleeding here. And it's an indication that IC green was misleading, that even though it looked like a dead aneurysm, it was not a dead aneurysm. So I'm applying another round of fenestrated or tandem clips, a feni and a closer, and that reinforces or boosts the closure. And here, just confirming good flow in the supraclinoid carotid and no filling of the aneurysm. Clips are off. You can see now the optic nerve is nicely decompressed. All of that pressure that was under has been relieved. Now this is a view of the neck. So we put our clips back on to isolate the bifurcation. We can come out with our catheter. And then this is just a figure-of-8 stitch to close things down. Now we reopen our carotid flow. And that's the end of the case. So show you, this is our setup for suction decompression, angiocath, and a 50 cc syringe. And she did well. This is her postoperative angiogram. You can see a good carotid reconstruction. You can see the clip configuration. And her vision was continued to be improved. So another interesting case, I think, again, like with your anterior carotid artery aneurysm that you showed us, this is one where I did something I don't normally do. I don't often use either a neck exposure or suction decompression, but in this case, I thought it added value. It's also a good lesson in how you can't always trust your IC green, even though it looked as though we had completely closed it. It was those closing clips were clearly not strong enough, and they needed some boosting. Anyway, what are your thoughts?
Yeah, same phenomenon happen often, even in such a large aneurysm. Even if you put the multiple clips and it looks good, IC green shows no filling, but sometimes aneurysm is still alive. So confirmation by puncturing aneurysm is very important in order, especially in order to decompress such a optic nerve symptomatic patient. The purpose is decompression of the optic nerve and to save the patient visual acuity, of course. So, and it's a very important confirmation. And when I performed the retrograde suction decompression, I cannulated the tubes through the suprathyroid. I have several experience to do a direct puncture to an internal carotid. But you may realize that if the patient have the plaque or trauma at the common carotid or internal carotid, it may be dangerous to make the something dissecting new region. So if possible, I recommend to use a superthyroid artery to cannulate into a common carotid, and then it's a safely you can suck the blood in aneurysm and ICA. But almost the logic of this procedure is the same. Concept is the same.
You made a comment earlier that you don't like to do anteroclinoidectomies as much now as you did in the past. I assume that you would have still done an anteroclinoidectomy on this case.
Yeah. I used to do a intradural anteroclinoidectomy until 20 years ago, when I learned skull-base surgery from Professor Fukushima. Before learning under Professor Fukushima, I always performed the intradural anteroclinoidectomy. But there was a difference in between intradural anteroclinoidectomy and the epidural anteroclinoidectomy. It's just the dura can protect any neural structure during anteroclinoidectomy. But this is a big advantage in epidural anteroclinoidectomy. But after the epidural anteroclinoidectomy, in my experience, around more than 200 cases, the visual disturbance after surgery, the visual disturbance ratio increased. During intradural anteroclinoidectomy, I have I had nothing of a visual deficit, including blind or partial visual disturbance, visual field disturbance. But after epidural anteroclinoidectomy, in these 20 years, I had a 17% of a visual field defect, and a 6 to 7% of blindness. You have already published about the visual disturbance after the paraclinoid aneurysm surgery. The visual disturbance ratio was lower. In your case, the result was lower than my result. So I am now looking back. What is the difference? What is wrong to causes such a severe disturbance? I am still considering, but one reason is this is my personal prediction. The one reason is when I do a epidural anteroclinoidectomy, I always cut the meningo-optal band, and inside the superoptal fissure, elevate the dura propria from a cavernous lateral wall. This may causes something the blood circulation of the optic sheath or orbit, maybe, because without anteroclinoidectomy, just a dura propria elevation without anteroclinoidectomy, I had one case of a visual deficit. And in that case, that is a distal basilar aneurysm. After clipping perfect, I didn't see the optic nerve. What I did, just elevate the dura propria to preserve the cerebral veins, sphenoparietal sinus, and clip the basilar aneurysm safely, but patient had a visual deficit. The operative side eye, the lower visual field disappeared. So just one possibility, maybe incision by the incision of a superoptal fissure and a meningo-optal band cutting. This may cause something the circulation, venous circulation, arterial circulation to the optic nerve or orbit. Because just after surgery, the patient have the very strong conjunctival eye swelling immediately after surgery. So in this 20 years, the intradural crinoidectomy, epidural anticrinodectomy, the difference is a dural protection, but without blood protection, intradural anticrinodectomy may be safer, especially
So
for visual function.
why do you then still do the extradural then?
Still I'm doing, but in this 3 months, I decided I tried to do an epidural anticrinoidectomy without meningopter band incision, superoptic fissure incision, preserving meningopter band, preserving superoptic fissure, and try to do anticrinoidectomy epidurally. It is a very narrow space, relatively difficult, but I'm trying now. I'm trying it now.
Okay, well, we've gone on for an hour and a half, and I know that you probably have a busy OR schedule for today, so I don't want to take too much of your day. It's great to see you. It's been way too long.
Good.
And I've missed seeing you. I've missed our chats, and I'll take this as a insufficient substitute, but we really appreciate you joining us. We appreciate you sharing these masterful cases, and it's always a pleasure to speak with you.
Yeah, thank you very much. Yeah, it was very good to see you and to see your cases and to see your new techniques. Yeah, and I can feel the atmosphere of Barrow. I think a young new residents, newcomers already joining to your institute. Congratulations, and see you again soon.
Yes, hopefully very soon.
Yeah.
All right, Reiner, I think we're wrapped up. Do you want to say any final closing words from the Aesculap Academy?
Hey, Dr. Lawton, Tanikawa. No, actually not. I'm still blown away by the cases. So you set the bar high for the next webinars to come. So thanks for sharing your expertise and thanks for having us. Yeah, looking forward to meet you all in person and thanks to all the participants for joining.
Yeah, and I would just put in a plug for our next Clippology. It'll be in a month or so. I believe it's in mid-November. Dr. Howard Rena and Dr. Adam Arthur are our next two guests, and we look forward to all of you joining us. Thank you.
Thank you.
Thank you.
Thank
Bye-bye.
Bye, Rokuya. Bye, Rokuya.
Bye-bye. Bye-bye, Michael. See you.